This recording is about death and dying. Um, it's for your patients, it's for you, and I find it to be quite informative, so hopefully y'all will too. I think this is a slide presentation that's a sad one, but it's also, if you'll look at it clinically and not look at it personally, you'll do much better. This is just some information that I've gathered, so I don't want you to think I'm an expert on this area. All right, strange as it may seem, death is a part of living. And we need to find out where we got our ideas about death. For me, mine goes with a little superstition. It does with a little experiences with death, and also what I've seen in the hospital. Religious beliefs, it also has to do with science and also family. So we're just going to consider this a teachable moment. When we go through this is something that we can store back. All right, first I want to talk about the hospice concept. Now, the hospice concept states the dying have a variety of physical, spiritual, emotional, and social needs. One of the things that people don't like hospice for is because they think if you go into hospice, you're going to die or they're going to kill you. I've heard older patients say, no, they'll kill you. You're not going to make it. But really, hospice is not that at all. Hospice is palliative rather than curative. Hospice is a concept that's supposed to help someone have a quality of life rather than quantity, because usually it's for our terminal patients or our patients that will be passing, or family members that will be passing within 6 months to a year. And this is supposed to be a concept or for comforting the dying. And professional medical care is still given. So if there is a medicine that that patient needs to be on, they're still going to have that. But they're also going to have nurses that visit them regularly and healthcare providers that's going to see how they can ease that dying process and also relieve any symptoms that may occur. The patient and the family are both included in the care plan. When it happens, everybody gets together that wants to get together. In some families, the family member doesn't want to be active. Also, they give emotional, spiritual, and practical support. Spiritual, if that family member believes in that. But all is given based on the patient's wishes and the family needs. And the patient comes first. Whatever that patient wants, that's what that patient's going to get. And these are trained volunteers, and they can also offer respite care for family members. Respite care is a provision for a short-term relief for the caregivers. It can be arranged for just an afternoon or for several days or weeks. Care can be provided at the home. It can be at a healthcare facility if it's needed, or it can be in an adult daycare. So we'll use me for an example. Let's say, for instance, that I started to work and I had to take my mom to the adult daycare center, which would be Caring Days. So it opened at 8:30. I was supposed to be at work at 8. So my hours were adjusted for that. I dropped Mom off at 8:30, but let's say I worked till 4:30, and that's when the daycare closed. So I had to make sure that I got there by 4:30. If I were going to go shopping for groceries, I would have to take my mother with me. So if there was something I needed to do, like going to the doctor, having an x-ray, or like an exam or a test in radiology, and it was going to be at a time that I could not take care of my mother, that I could ask for hospice to do a respite or give me a break, so to speak, if I was in the hospice situation. So the hospice concept regards dying as a normal process. It neither hastens or postpones the death, and it provides a personal service. Hospice care is provided to patients who have a limited care expectancy, and they accept anyone regardless of age or type of illness. And they also, these patients are, if they're capable, have made this decision to spend their last months at home in their home-like setting. I'm sure most of you have seen those commercials where it says caring for mom at home. So when a person enters the final stage of the dying process, there's two different dynamics that are at work. There's the physical plane. Now, your body is going to go through a physical process of dying, and that's just natural. But the emotional and spiritual and mental plane is quite different. It tells us here that the spirit of the dying person begins the final process of release from the body, its immediate environment, and all attachments. Now, before you start talking about spiritual and the spirit leaving, there are some people that do not believe this. So usually when we talk about death and dying, we talk about the rad tech's job, which we'll talk about that in a moment. But I want you to understand that you may run into a case, or you may run into even a family situation where people feel different about the spirit. It also may include resolutions of unfinished business that patient or family member may not have finished. And it may need a it's okay to go from family members. Now, we'll talk about that in a moment, but that kind of sounds strange to some of us, that the family needs to tell somebody it's okay to go. But that's important. But we can tell you some things that you may see. So preparing for the final stage, our patients will get very, very cold. Coolness of their skin and their body is a normal indication that the blood is decreasing to the body extremities and it's going to their vital organs. This is not the time to put a heating blanket on those patients. And also, it's not the time for you to go in and when you touch your patient, when you're doing a portable exam, please don't say, "Oh my gosh, you're so cold." If that patient is responding to you and they're looking at you and they're talking and you feel that they're cold, what you should say is, "Would you like a blanket? Would you like a warm blanket?" But the best thing is not to say what you observe. The patient will begin to sleep a lot more. They'll be sleeping all the time. So you may go into do a portable, and when you do, you'll see a family member sitting there, and the patient will be asleep. Please make sure that when you do that, use hushed tones. Be quiet. Walk in and introduce yourself. "Yes, I'm from X-ray. We're here to do a chest X-ray the doctor ordered." And then speak to the family member and say, "May we wake her up?" The family member may tell you she's not going to wake up, or they may reach over and say, "Mom," in this case, they're here to do a portable chest. Or you could go up, touch the patient gently on the shoulder, or touch the bed and say, "Miss whoever, we're here from X-ray to do a chest X-ray." Now, they may or may not respond. If they don't respond, please remember they can still hear you. Be very gentle when you're adjusting the body. Go ahead and put the portable detector behind their back or whatever you're x-raying and perform your exam. Thank them and leave that patient as they were when you came in. If they were on their side, you leave them that way. You'll also see patients withdraw. They'll be unresponsive, withdrawn, and in a comatose-like state. This indicates that that body and that person's preparation for release or passing. They'll detach from surroundings and relationships, and it's kind of a stage of letting go. Now, we see this more really in before they come to the hospital, that they'll start letting go of things and detaching from relationships. But once they come into the hospital, they usually get to where they're sleeping, and then they'll become unresponsive and withdrawn. But please be careful, hearing remains all the way to the end. Speak in your normal tone of voice. Always identify yourself and tell them who you are and where you're from. If this is a family member, it's okay to hold his or her hand and say whatever you need to say to help that person let go. But for a patient, we want to make sure that we identify ourselves and tell them everything that you're doing. Miss so-and-so, I'm lifting you up to put our detector behind your back, things like that. Our patients do get confused about time, place, and people. They're going to get, I call it hospital dementia. Sometimes after you're in the hospital so long, all the days run together. But when you walk into the room, you want to make sure you identify yourself by name. Don't speak too softly, but don't be hollering. Speak clearly and truthfully. And don't ask the patient to guess why we're here. You want to tell them who you are. If you see family members, sometimes they'll say, do you know who I am? That's not what you need to say to a patient that's going through a confusion. Just go ahead and identify yourself as a family member. But for a technologist, we want to make sure that we identify ourselves so they'll know that their doctor has ordered this exam. Now, when we're x-raying our patients or when we're with family members, incontinence is not universal. Make sure that if you're in there x-raying a patient and they've got the blue pad, make sure that it's still up underneath them. If they ask for to go to a bedpan, you make sure you get the nurses in there because they may need to move that patient and help you. But if it's someone that's in hospice, they'll usually use a chucks instead of a bedpan for bowel movements. There may be a Foley or a condom catheter that's used because they have urinary incontinence, and there's care challenges relating to the toiletries. So you want to make sure if that patient's wet that you notify the nurse. They should know it already, but it's not good for a patient to lie in a wet area. And that means for our patients in the hospital also. You don't know how long they're going to sit outside and wait for a transporter to take them back to their room. So try to also take care of your patients in the department. You may see patients have the Depends that are on the left, and they have here at the hospital, they have the adult diapers. That's really easy to take on and off, but you still need to clean those patients if you're going to change their diaper. If you change a diaper in a department, let's say you're in fluoro and your patient's been with you for a while and you have to change that, you want to make sure you notify the floor and the nurse in charge that they either urinated or either had a bowel movement in your department. Patients a lot of times get congested. One of the things that I've heard people say is, why am I doing this chest x-ray? I mean, they're a DNR, which means do not resuscitate. So do not resuscitate doesn't mean no care. It means if their heart stops or something like that, you don't do CPR. But in the case of congestion, which I don't know if you can see it on the left side in this area here, they could actually do a chest x-ray and then do a thoracentesis or put a needle in that area and draw some of that fluid off, and that would help that patient be less short of breath. So your chest x-ray is doing a good job. It's not just getting insurance money. Respiratory secretions usually occur a lot in the last hours of life. You'll go and do portables and you may see your patient not being able to cough or swallow, and you'll hear this noise in the throat when they're breathing and gurgling. You'll hear techs say that is called the death rattle. For management, that patient is unable to clear their throat. So you do not want to lay them flat or leave them flat if that's how you did their chest x-ray. Hopefully you didn't. Usually those patients are sitting semi-erect or erect, so you want to leave them like that because that helps them avoid choking or gurgling so much. Um, they do not like to suction patients that have problems swallowing. The reason why is because suctioning usually makes the patient nauseated. So that we don't want that to happen. But they may give medication, which are called anticholinergics. I never can say that word right. What the bottom line is, it decreases saliva. Atropine drops may be given on their tongue that can reduce saliva, but if they give something else, it may also have a sedation effect, so they may not be able to move for you as well. They may also reduce or stop fluid intake or hydrate because the body cannot eliminate it. So you don't want to keep giving fluids if it keeps building up and they cannot eliminate the fluids. So what does that mean for the techs? Well, you'll see the room should be cool. If it's a patient at home, there may be fans blowing. Leave the patient as they were. They should be elevated. And the thoracentesis, which I told you about, where they draw the fluid off the lungs, usually you have to do a chest x-ray for that, and that helps them. But one of the things is you want to have a calm environment. Even on the floor, if these two nurses are playing and squirting each other with water and screaming and laughing, you're going to hear that in that room. And that's quite upsetting for a family member. So if you're laughing and cutting up coming down the hall, even if you go into that room and you're quiet, you still made a noise. You still cut up. And people do not forget that. And that also hurts, I hate to say, our patient satisfaction because that's important for us. So make sure you remember where you are when you're going to do that portable. 70% of our terminally ill have shortness of breath. 90% of our lung cancer patients can't breathe. But that's a subjective. I can't really say that. I can't say shortness of breath. What you can do is they can say, patient states they're having shortness of breath, having difficulty of breathing. That could mean a pulmonary emboli, which means a blood clot that has gone to their lungs. That could mean pneumonia. That could mean a buildup of fluid. We can't say that they've got pneumonia. We can't say that they've got a buildup of fluid. We don't know that without the doctor reading that. But I do know if that my patient tells me that they're having trouble breathing and they feel like they can't get a deep breath in, that is a functional status. That means that I can do a respiratory rate. I can see if they've got agonal respirations, which we watch during CPR. We can see the use of accessory muscles, which is the muscles in their neck standing out as they're trying to breathe. You can see them in pain when they're breathing. You can hear those breath sounds. Those are functional status signs that nurse will document. But for us, we need to make sure that we put the right history so our doctor will read that right. Breathing pattern change. There's two breath patterns that I want you to know about. One is the first one, Cheyne-Stokes. It's irregular, shallow breaths with period of no breathing for 5 to 30 seconds, up to a full minute. Now, if somebody doesn't breathe for a full minute, I'm going to freak out. That's just me. BOs are cluster breaths. They're quick, shallow inspirations followed by regular or irregular periods of apnea. I'm so glad you're learning this now, because back in the 70s when I was in school in the 80s, nobody told us about this. We didn't have what you've got, all these classes. We had some, but Cheyne-Stokes, I must have not been in patient care for that day. So I get a patient into the x-ray room by myself, and I'm a student, and she's elevated. I put her on the table because I have to do a flat and erect abdomen. She's 93. She's not responsive. I lay her down. She stops breathing. I sit her back up. She starts breathing. I lay her down. She stops breathing. I start screaming for help because I'm like, I don't know what's going on. If they had told me in the emergency room when I brought her over that she was chain stoking, I would have maybe understood that those were irregular breaths that can go up for a minute. Also, it says elevating the head and or turning the person onto their side may bring comfort. That's if you're with somebody during hospice. But for our patients, we don't turn them unless the nurse tells us that we need to. Usually the nurse has a chart on the wall, and you may see that when you do portables. It looks like a big clock, and that lets you know how they're turning that patient. If this is a family member, you can hold their hands and speak gently. Our patient also may have anxiety symptoms. They may be irritable. They may not be able to sleep. If you touch them, they may jump and holler because that would be an exaggerated startle response. And they may panic. If something like that happens, you can talk to the nurses if they're not going to let you x-ray them. But usually for anxiety management in the hospital, they're going to give them something that's going to help them. But if it's a hospice, they're going to talk about, I've never seen hypnosis, but the text state that you may talk about an image or something that you used to do with your family member and relaxation techniques. When it comes to anxiety and depression and distress, the family dynamics have a lot to do with that. I went into the emergency room one night to x-ray an older man, and all the family had their back to him with the nurse, and they were talking about, which I didn't gather at the time, putting him in a nursing home. And I made the fatal mistake of saying, how are you doing tonight? And I got really talked bad too. But you know what? I probably shouldn't have asked that question. What I should have said is, hi, my name's Deborah, and I'm here to do an x-ray. So the family, he was mad because the family was over there talking about putting him in a nursing home. So there may be some emotional turmoil at the time. So when you go into a room, you never know what's going to happen as far as what has happened. But anxiety and depression are common in people that have life-threatening illnesses. And patients near the end of the life are more vulnerable because they are depressed. Life is changing for them, and it puts them in a great bit of distress. Our patients are in the hospital, and they don't want to be there. They want to go home. So that adds to the anxiety and the depression and the distress that they have. And there's a relationship between the perception of the quality of life and the presence of discomfort. So it's kind of funny. If you look at how patients were, the circumstances they were born into, and how they feel, and then the outer world, all of that blends together. Let's use this for an example. My sister, who is younger than me, had a COVID test, but she's also had 3 sinus surgeries, or scopes. So they've gone up her nose with these scopes. When they did the COVID test, she didn't even blink. The nurses couldn't get over it. But see, her presence of discomfort wasn't that big of a deal because she'd had things scopes up her nose. My father was another example. He was 88 and fell and broke his nose. He never complained. His blood pressure was up because you knew that he was in pain. But he had been in the Army, and his quality of life was a little bit different because he had been a boxer. So it didn't bother him. In fact, he said when he hit the ground and broke his nose, he felt like he said it was the same feeling he had in the only fight he did not win in the Army. And he said every time that guy hit him, he saw lightning. He said, and I saw lightning for sure when I hit that ground. So there's a lot of perception. There's a relationship on your quality of life and the presence of discomfort. If you've got a great life and you enjoy it, those patients may not be as discomforted or distressed or depressed as a lot of people. But then again, if they've got a great life and they don't want to give it up. So you never know. You just have to take, I guess, as they say, the patient that was dealt to you and make sure that you're always the professional. Our patients do get restless. You won't usually hear music in the hospital, or not here. But if they were at home in hospice, there may be music. It may be something very instrumental. It may be country for our older patients. But you may walk into a room that has something low and playing. I know that when my aunt passed and we knew that she was passing, her daughter was sang in the choir. And she stood at the bottom of her bed and sang a church song. That was her favorite song. And all the nurses talked about it later because it was in ICU and her slow, low voice still resonated through the halls. But it calmed that restlessness that my aunt was having because she was trying to tell everybody not to worry. Some patients will apologize for you having to come in and x-ray them because they feel like they've put you out, or if they've got let's say COVID, or they've got HIV, or they've got something that's communicable, they may apologize for actually exposing you to that disease. Unfortunately, I've had that happen to me, and it's quite unsettling when a patient tells you how sorry they are to you for you doing your job, for taking care of them. When you see restlessness, you may see this in the hospital. You may see the person perform repetitive and restless tasks. One of the things we see is them picking at bed sheets. Some people think that's something unresolved and unfinished. It may not be. Everybody's different. What if that person was a needlepoint or a knitter? They may be doing something that in their mind at the time is calming to them. Terminal restlessness is usually what that's called. It can be caused by dehydration, decreased oxygen, anemia, which means, their red blood cells are decreased. If they've got a fever, an infection, brain tumors, UTI, constipation, fecal impaction. Look at all the things that can happen. So, and then your patient that is dying is going to go through metabolic disturbances, common at the end of life. So sometimes terminal restlessness is maybe because of medication, but it may be just a repetitive thing that patient did when they were younger. A person may nervously pick at their sheets and clothing. They may even hallucinate and see people and things that aren't there. Please don't play into that. I find that quite unsettling for a student that walks in there and acts like they see somebody and talk to them that the patient's doing that to. Keep your mind on your task and do it and get away. It may not be well received by family members or other healthcare professionals. Terminal restlessness usually is only addressed or treated if that person is going to hurt themselves or someone else. So there may be calming activities that you could use. We usually say in the elder community to redirect. If someone gets upset, then redirect. If you have that, but that even works with our intoxicated patients. I'm going to use that as an example. You have a patient comes in and he's mad at a nurse and he keeps fussing about that and he's escalating. Then you could redirect and talk to him about, well, tell me, is your doctor doing okay? Have you been seen by the doctor? Have you had an x-ray before? We're going to do an abdomen x-ray. We're going to x-ray your face, whatever you're doing. So you can redirect. So calming activities would be like, let's recall a special place that that person enjoyed, or a favorite experience, or read something comforting, play music. These are things that you would do to a family member or hospice would do. For instance, in elder care, nursing homes, or elder care, adult care, daycares, they'll often play music that was indicative of that person's life. For instance, my mother, we'll use her as an example. She loved country music. Most older people in their 90s do. So her daycare that she went to would play often country music for everyone to hear. Urine production will be decreased in the end of life. If you notice here on the bottom left, you can see it's just a little golden. That's okay. But when the end of life comes, you can see it become tea colored and even darker. It's referred to as concentrated urine, and it's due to decreased fluid intake and a decrease in the circulation of the kidneys. So when you walk in there and that patient is there and it looks like there's coffee almost, it's so dark, or Coke in their urine bag, do not make a comment about that. Just ignore it because you're in there to do a chest x-ray, not to comment about the urine. Fluid intake and food decreasing, it's going to decrease. And it's just the body's way of conserving energy. Don't force food or drink if it's in a hospice situation. Fluid can be given in small amounts by syringe. And you'll see glycerin swabs maybe on the side table in the patient's room that you're doing the portable on. And that keeps the mouth and lips moist and it keeps them comfortable. You may see ice chips, or they may give a little bit of Gatorade or a little bit of juice, but that's just the decreasing of intake, basically, is what that patient will be doing. There's also a change of consistency of foods and or fluid. You may see our older patients come in for modified barium swallow, and they're seeing if they can swallow, because if they can't swallow, usually that food or liquid is going to their lungs and they're going to get aspiration pneumonia, which can be fatal. So if they don't have the ability to swallow pills or food, then that's going to have to change how their medicine is given. But each family member needs to know the natural progression of the disease and the dying process, which means little interest in food. I personally, when my mom was sick, I got a little upset about her not wanting to eat. I have a close friend that her husband was in hospice, and she refused to let him go. So what she would do is she would feed him fruit cocktail, and she would blend it up and give it to him because she kept thinking, if you eat, you'll get stronger. But remember, we just got through saying, it's that way of that body letting go. Now, let's just say, for instance, you're in the room and somebody's force-feeding somebody that doesn't want it. I don't think there's a problem with you as a student telling the tech. You think, well, I should tell the nurse about that? As a tech, I probably would walk down there and say, can I speak to the nurse in charge of room 386 or whatever? And then I would say, I just wanted you to know that the family member's force-feeding food down there. And that might be a problem. But thank you for letting me tell you, and then walk off. That's a teachable moment. The nurse is going to do what they want to, but usually they're going to go in there and say something. Nausea is also something that you may see, and when you move your patient for your portable, they may get a little nauseated. They may have a bowel obstruction, they may be constipated, but you know what? So you don't know if your patient may be having chemo or radiation therapy. So any type of movement. Let me talk about chemo and radiation therapy for a minute. Our patients that are having chemo and are having therapy like that, they do not like any type of smells. I know you love your hair to smell good and you love to put an extra bounce sheet in the dryer, but be very, very careful because your nose gets, as they say, nose blind, but that patient is more sensitive than normal. So our chemo patients get very, very sick if they smell anything like that. Also, our patients that are waking up from surgery. So if you get somebody that's already having problems with the anesthesia and you walk in there with your great smelling hair or your extra bounce sheet or your good smelling deodorant, that's going to make them sicker. So make sure that we're still a no smell facility. Delirium is Latin for off the track, which, I don't want y'all to be talking about me being off the track, but up to 85% of people in the last week of life have delirium. And it could be because the organ failure or medicine. It could be because of infection, but usually it's because of organ failure and the body shutting down. There's used to be a show called Raising Hope, which was a kid. But anyway, I got used to really get tickled at the lady that played the grandmother. Notice she says, one of you help me take the batteries out of this doll, talking about the baby. So you may see them say different things. That's off the track. And then they may have vision-like experiences. The eye only see what the mind is prepared to comprehend, is what they say. So you may go into a room and they may call you their daughter, or they may call you their son. You never know what their vision may let them see. Most of the time, you'll hear people talking about they are seeing Jesus. You'll hear, they were talking about they saw Jesus. Where I come from, not the New Orleans saints, but where I come from, my raising, they see saints. When my dad first got Parkinson's and his eyes, he was going blind at the same time. Parkinson's disease also has hallucinations with it. So with him, he started seeing things that weren't there, which concerned us. But when they gave him the Parkinson diagnosis, they gave him some medicine. He got over it. So he's sitting in the chair and he's outside and he said, "Do you see Mama out there?" And his mother's been dead for years. And of course, my mother looked at me and we said, "Oh my gosh, the saints are coming to get him." And you may hear that, but it could be because of the physical problems like organ failure. It could be because of something like Parkinson's, Lewy bodies, Alzheimer's, any type of cognitive dementia. There's a lot of things that go on. And remember, we talked earlier in this presentation about superstitions and family. That has a lot to do with it also. At the end of time, people don't want to be with a lot of people. They are preparing for release. And you may hear your patient talk about, "No, why is everybody treating me so mean?" That's a difficult patient to x-ray. But you have to reassure them, "No, ma'am, we're helping you. We're helping you. We want you to feel good." I don't feel comfortable saying I want a patient to feel better if I know that they're terminal. But that's just me. That may be something you can do. There may be some unusual communication. For this slide, it's for hospice. If somebody is out of character, they could be testing you, giving you some kind of case scenario or something that happened when you were little to see if you really loved them as a parent or an aunt or whatever. But if they tell you that they love you or they do something or make a gesture, please, if that's that patient or that your family member's last moment, accept that as a beautiful gift and then do whatever you need to say. But for our patients, please realize that what you see after a terminal illness or after a stroke or at the end of life may not be that person. I have a very close friend that I knew in Louisiana, and her husband had a stroke, and he was a physician, and he was a wonderful Christian man. But after his stroke, he talked so bad and so nasty, she got so upset that he was always the last patient of the day for any doctor appointment that he ever went to. And when they went to the emergency room, she had to ask them to please put them in a room that had a door because his communication was so vulgar. And she was very upset because she said, "That's not my husband. He would never say those things." So if somebody says something to you in a rude way, realize that that may be unusual communication, and even if it's not, you still have a job to do. This is a teachable moment that I saw when I first started teaching with one of my students. It says a dying person will normally try to hold on, even though it begins prolonged discomfort, in order to be sure those who are going to be left behind will be all right. The greatest gift that you can give a family member that's passing is to say it's okay. I know of a technologist that asked their mother to stay, and she was terminal, and she was very thin and very sick, and nobody noticed that he was going in there asking her not to leave him. Hospice realized it because his mother was in hospice. They took him to the side and said, "You can't do this. You have to tell her it's okay to go." And he went in there and told his mother he loved her, it was okay to go. And when the 30 minutes she had passed, that was a real teachable moment for me. Yeah, it may be sad, and I don't want to make you sad, but it was a teachable moment because then it realized that your spirit can be so much stronger. It's sort of like I heard years ago on Paul Harvey, which is way past your age. He tells a story of this man that cut his throat with a chainsaw, and he should have died. But he grabbed his throat, got in the car, and drove to the hospital, and they saved him. And they asked him what made him get in the car and drive to the hospital. And he said, "My wife was sick." I have a friend, he's passed now, that had, I'm from the country. He got his leg cut off in a corn picker. And he tied a bandana above his knee, got in his standard truck. It wasn't automatic, drove himself to the hospital and made it. It was the same thing. So people, and you've probably heard stories all your life, or you will hear stories. People's spirit is so strong. So it's okay to give permission if this is a family member. We don't give permission to our patients. But this is a teachable moment because I would have never thought it, and I was very young back then when this first happened. Final gift, this is my hard part, is basically saying goodbye, and that is hard. So if you go into a room that you know that patient is passing to do an x-ray, please keep your voice lowered, be very quiet, and also make sure that you don't look around. Just take care of your patient. And if the family member's upset, please don't go into it. Just do your job. And that's what's so hard. We don't give primary care, so we don't know what's going on. That's what that nurse does. We kind of come in and come out. But look, guys, that's why y'all wanted rad tech. You didn't want to be a nurse because you didn't want to be a primary care person. You wanted to assist the radiologist. You wanted to assist that patient. And by doing that in their room, that's going to be a good thing. So this may have taken you down memory lane. I certainly hope that it hasn't. And I hope that this hasn't hurt your feelings too much because it's a kind of a tough thing to go through. And the bottom line is, no matter what, make sure that if it's a family member, you make sure you tell them you love them. And if that patient tells you that they love you, you tell them that you love them back too, if they're in their final days. Now, if you get, and I'm not trying to make a joke here, but if you've got that patient that's intoxicated and he tells you he loves you, you might not want to tell him the same thing, or at least turn your badge over so he can't see your name. And thank you for listening to me, and thank you for putting up with this, but it's something that you may see. If you ever have a hard time in the clinical area, please come down to the school or go around to Kim's office and call me. I'll come up there. And this is the difficult part of our job. And sometimes memories sneak out of our eyes and roll down our cheeks. I love that. So no one told you not to laugh. No one should tell you not to cry. When death has occurred, you may be prepared for the death process, but you may not be prepared for the actual death moment. Sometimes we have to x-ray people that have already expired, as they say. How will you know when death has occurred? It'll be helpful for you and your family to think about this and discuss if it's the patient is your family member in their hospice, because hospice patients aren't an emergency, so nothing has to be done immediately. In the hospital, you may see them prepare the body, which means that they'll tuck a sheet around the patient and clean their face or their hands or whatever they may need to. And they may let their family member come in and stay with them for a while. And that's okay too. Of course, sometimes if they need that ER room or they need that CT room, they may not do that. So if it's at home with hospice, the body doesn't have to be removed until they're ready. If the family wants to assist in preparing the body by bathing or dressing, that can be done. I have a good friend that she lost her child and he had cancer, and that's what she did. I mean, that was her last gift, and she talked about it at the funeral, and she was very, very happy. Call the funeral home when you're ready to have the body moved and identify the person as a hospice patient. Usually here in Tuscaloosa, the first thing we do, if they're with hospice, hospice will take care of it. If it's a hospice patient, then the nurse should be notified first, and then they ask, do you want us to call, I think it's 311, which is the city number, or 911, and say it's not an emergency. But usually the hospice nurse takes care of all of that for the family. The police do not need to be called. It's not an emergency. The hospice nurse notifies the physician, and that's really good because the quality of dying is important for the patient and the family. And the memory of the death experience is life-altering for survivors. So when we did the CPR, I told you that we don't want a family member to come in and see us doing CPR because they will never get over that experience. So we want to make sure that we are as professional as possible and we take care of the family members that are visiting here. So let's say that you're in the room and you're doing a chest x-ray and the patient codes and the family's standing there. You reach over, you call the nurse and say, I think we have a code blue. They'll come in, but somebody needs to escort the family member out. It's not only about the dying family that we have an impact on also. It's an impact on each other and our healthcare professionals. So what are some appropriate things to say? I'm just going to go ahead and pass this in case somebody passes. I just want you to know I'm thinking about you. It's okay to cry. Not to say if somebody has passed and you're talking to a family member, cheer up. I love that commercial that says, I've got depression and my daddy says, snap out of it. So you don't want to say cheer up. Time will heal all wounds. Old people love to say that. She or he is better off. I don't want to hear that either. And it was God's will. Sometimes people go through an angry process, and Miss Ashley is going to teach you about Elizabeth Kubler-Ross and Abraham Maslow. Those are two theories. But one of the things with Elizabeth Kubler-Ross is the first thing is denial that the person is gone. The second thing is anger. So if you say it's God's will and they're in the anger part, that's not going to be a good thing. Call me if you need me. It's best not to say call me if you need me. And this is my favorite, and I actually heard this in a funeral home. He sure lost a lot of weight. Did y'all feed him? But remember, we said in the end of time, a lot of people stop eating. And this actually was said to someone who was in primary care, a giver of a patient that had Alzheimer's that quit eating. How sad for that family member. So there's a lot of areas here that we talk about, especially since we're familiar with the DCH Cancer Center. Maybe we're going to go on a tour and I'll take you through that. And I talk a lot about that system because I think it's awesome that we have that right here. There is a book out here that's written how the medical system is failing the elderly, especially in day and age now that a lot of younger people don't respect older people. We've got St. Jude's Children. There's a lot of things that you may see that hospice will be involved with. And there's this saying that says, I'm not afraid of death, I just don't want to be there when it happens. Disease and death is not shameful, and a distracted life is not a full life. So accepting what cannot be changed reduces suffering, and death reveals the importance of love. You make such a wonderful difference in those around you. As a tech, you do. When you walk into that room and you've got a slight smile, but you're very serious, and you say, "My name is, I'm from imaging. I'm supposed to be taking a chest x-ray your doctor has ordered. What can I do to make you comfortable before I leave?" You make sure that you have a good day. I hope, if somebody needs something to eat and they're waiting on lunch, you say, "Well, I hope it's going to be a great lunch for you." Something nice like that is really makes a wonderful difference. I will tell you that one of my students called me the other day and was telling me of a story about they thanked me for teaching them the last chapter. And the reason why is because I feel like everything that we go through in our life is a chapter in our book. So my student gave me a call, and she said, "Michelle, please tell me that you're still teaching the last chapter." She's a student from years back. And she said, "Today I was in a case, and a patient walked in, and radiology, and this student lives out of state. She lives nowhere near here." And she said, "I was walked in the case, and we were doing the case, and the patient passed. They died." And she said she'd walked in, everything was great. And she said it wasn't a hospital error. It was just her body. I can't explain it because of HIPAA. But she said the techs that were working on her were devastated. And she said, "I was able to tell them your last chapter philosophy." So this is my last chapter philosophy. If you imagine our patient's life as a book, and they are born, and they have childhood experiences, and they get married, and they have children experiences, and they grow old, and then they pass. That's what you would think, right? But it's not always that way. They may get to the marriage part, and they may have an illness. No matter what, at the end of their life, that's their last chapter. So we all have a book, and every quarter will be a chapter in our life. So she sat down with these techs that were devastated. They were in tears, she said. And she talked about how they received that patient. They talked to her. They got her dressed, made sure she was warm, told her they were going to take care of her to the best of their ability, asked her about her family, and made her feel important. Her last chapter, that patient's last chapter, was a good chapter because they made her feel important and loved and worth the test that she was going through. So, you'll hear me saying everybody hates me when they get through 7th and 8th quarter because that's their last chapter of school. And I do get quite difficult and give terrible tests, and sometimes I can just be really a smarty and be mean because I see the potential in each one of my students, and I know they can pass if they'll just put it out there and work hard. So, the last chapter philosophy is just what I said. The last chapter, you never know when that patient that you're x-raying is their last chapter. So if you're rude to that patient, that's what they're going to remember. I wasn't worthy of having respect when I'm paying for this exam and wanting a good or bad diagnosis. I just got to find out what's wrong with me. So the last chapter. Thank you for your time, and that was your most thoughtful gift